We very much look forward to another webinar that engages us as a community and brings us together. So the topic that we have this afternoon, I guess it wasn't a complete surprise, but nevertheless, I think that we all feel really shocked at the choppy seas that we find ourselves in again. And this includes the sudden suspension of USAID funding, followed by the suspension of PEPFAR and CDC funding. And to be honest, it comes, it goes. It's very difficult to even keep up with where we're at. And then at the moment, we're facing the possibility of suspension of National Institutes of Health funding, which is for our research. So we are feeling it in every way, shape, or form. And I think it's normal to feel perhaps angry, but it's also to feel perhaps a huge sense of despondence at the situation that we find ourselves in. So, and it's difficult to even grip the situation. We find ourselves in such choppy waters. So my name is Susan Cleary. I'm Professor of Health Economics at the University of Cape Town, and I am the Director of the School of Public Health. And it's an honor to be able to facilitate this afternoon with my colleague, Dr. Reno Morar, who's going to take over from me in a bit. And so I'd like to encourage everybody to engage on the chat. We will also have opportunities later for people to turn their cameras on and use audio and speak out loud, or if they prefer to engage on the chat. But we very much welcome your thoughts and your engagement. And as usual, this is a safe space of colleagues where we're trying to make sense of the situation together, and perhaps to think of the opportunity for learning as one thing that we can hold on to while we find ourselves in once again, very difficult waters. So let me first introduce our speakers, because their lovely pictures are up on the slide. Actually, Carissa, can we go to the next slide and let's ask people to start doing the Mentimeter. So we would like you to, as usual, we would like you to engage on our Menti. And so you just scan that code thingy with your cell phone. And the question that we have for you is, how much has your work been affected by the current US funding challenges? So please go ahead and do that in the meantime, and then I will introduce our speakers. So we have three speakers this afternoon. The first is Dr. Jabulani Mndebele, who is the Chief Director for the DHS in the KwaZulu-Natal Department of Health. We also have Dr. Hassan Mahomed, who is standing in for Dr. Gio Perez, who is unfortunately unwell. But we do see that Gio has joined us this afternoon, and we're very grateful to have you here, and we look forward to also hearing your thoughts. So Dr. Hassan Mahomed is a public health medicine specialist in the Metro Health Services of the Western Cape Government Department of Health and Wellness. And then our third speaker is Dr. Cheryl Nelson, who is Chief Director of Primary Health Care for the Mpumalanga Department of Health. So welcome, colleagues, and please, if you're able to, turn on your videos and your audio, and let's see your beautiful faces. And then we'll get going. I do not see any of you yet. Oh, there's Jabu. Hi, Gio. Okay, colleagues, so if you could keep your cameras on if possible while we start going into our discussion. And so the question that I would like to start posing for you is the question of, how has the uncertainty and the transitions of US funding impacted on the DHS in your province? And I'm going to come to you first, Jabu, please.
Good afternoon, colleagues, and I'm happy to be here. So, in responding to the question that you have asked, there are two answers that I'm going to give. One answer says, from my side, maybe this is the opportunity for the government to actually assess its own gap in terms of the provision of health services. Because, the funding was also perpetuating the management of a person as a disease, not as a whole person. Because if you get funding for HIV/AIDS, you are saying that person is an HIV, because it excludes the other issues that that individual is being faced with. For an example, the same person suffer from TB, he suffer from diabetes, he suffer from other chronic illnesses. So what does it mean if you issue funding just to look at HIV alone? So it was not promoting the actual people-centered approach. However, the impact of the funding in the province it affected mostly the community-based program, primary health care, of which is a priority of this government. In terms of the curative, the clinical care, it didn't affect it much. But primary health care in the programs that deals with preventive, promotive, rehabilitation, so we're also dent. And also on the issues of other systems, because I know one NGO is running a huge system on CCMDD, a system which as government we are supposed to have it. But fortunately, because they were innovative enough, they started the system. So the pulling off in terms of funding, it will mean that as government, we actually need to take over that function. And the critical part is that this caught us off guard. Like we never have time to actually prepare for it. It was like today, tomorrow we are stopping all the funding.
Mm.
So we needed to juggle around, because the partners are offering programs like your CCMDD. They invested a lot on other programs that they actually supporting us. So we needed to actually overnight think, how do we keep the same services going, of which in other instances it becomes impossible. But I still say this is a very good lesson for our country, so that we can put up systems that can sustain the whole country, and systems and the system that we can afford. Because if we invest on the primary healthcare approach, if we invest on preventive and promotive, we could be able to survive if there is total withdrawal of the funding. So I think I have to stop there.
Thank you so much, Jabu. Hassan, what are your thoughts?
Thanks. Yeah, thanks for this opportunity. And again, I think as mentioned, I'm giving this input on behalf of Gio. Gio is the district manager, and I'm one of his support staff. But he is here as well. But I'm going to try and channel him, which is not going to be easy. I'm sure you will step in if I, put the foot wrong. Fortunately, we were having a discussion with our NGOs this morning, and someone showed a very interesting summary slide of how the province has been affected. So I'm going to just give you an idea of how the province has been affected. So 882 jobs were affected in terms of being lost. 12 non-governmental organizations, and 3 districts. So 3 out of our 6 districts: Cape Town, Cape Winelands, and the West Coast. And then I was quite gobsmacked to see that the grant value that was lost is 407 million rand. And that's a huge amount of, so in terms of funding, that's a huge cut. And I think, as Jabu has mentioned, this was at very short notice. It was precipitous. So I think the key word to use was disruptive. What happened was extremely disruptive because it happened over a very quick period. 2 things I want to mention is in terms of how we're not affected. And one is in terms of ARVs. The province purchased its own ARVs, so there was no loss in the supply of ARV medication. Secondly, the Western Cape has the CDU and not the CCMD. So we were the one province that was not affected by the CCMD. And again, just to remind everyone, this is a drug delivery program to enable easy access by patients to their medication. So using various sites to enable people to get access at a local pharmacy or at a non-governmental organization office, etc. So fortunately, our province was not affected by that. So how were we affected? So there's 2 main sort of categories in which we were affected. One was direct service delivery, and the second group is what's called technical support. So what I mean by direct service delivery, so nurses, doctors, pharmacy assistants, data capturers, counselors were the type of staff that we lost. And, again, the impact of that loss was immediate and affected how effective our services functioned. I think one subset was what's referred to as key population. So there are certain vulnerable groups that are looked after by non-governmental organizations. The one group is the trans community, and the other group are men who have sex with men. So for reasons of stigma, they often don't use public sector services. So the non-governmental organizations take care of that. But 2 clinics in Cape Town were shut down at short notice. And a plan has had to be made to accommodate those clients elsewhere. So our pharmacies, our caregiving, through nurses and doctors was affected, and then data capture, which is again, it's a support function, but it's an important, really important function in terms of ensuring that our data is up to date so that managers can make good decisions and that we can perform proper monitoring of our services. And that was really quite seriously affected, particularly with respect to TB and HIV. So a lot of the funding was focused on TB and HIV, and important to emphasize that. And that's where a lot of disruption occurred. And then in terms of technical support, things like quality improvement projects, data processing, coordination of services, just provide what we call broadly health system strengthening activities. It's a big, broad term, but just stepping in here or there, helping us to observe how the health service is being run, making suggestions about how we can, improve services, facilitating processes. That's the second area. And although the impact of that is not as immediate, the impact on that we expect to be more long term. But let me stop there. Thanks.
So thanks so much, Hassan. So some similarities in terms of it caught us off guard, or it was extremely unexpected. And I'm going to come to Cheryl next, but I'm also going to ask the audience who is similarly affected to also start thinking about if you have any stories to share with us. So, for example, in the academic space, facing the NIH funding cuts, the short notice aspect, but also the retrenchment costs when your funding is cut, and there's a process of retrenchment that takes quite a long time. In addition to the absolutely awful thing of retrenching staff, there is who is going to pay that gap between the stop order and when the retrenchment process is actually finalized. So those are some of the larger concerns that we have in my space. And then Hassan, I'm going to come back to you in a second, but I'd also like to get a sense of how does this compare to last year's budget cuts? So we know that there was budget cuts coming through last year as a result of austerity in South Africa. And just to get a sense of how does this compare to what we went through last year, when you were cut last year and now a different kind of a cut this year. So if you could just think about that, I'm going to come back to you now. So Cheryl, let's hear from you. How has this impacted on your side in Mpumalanga, please?
Oh, good afternoon, Chair, and good afternoon to all present on this platform this beautiful afternoon. Yeah, indeed, the unexpected, abrupt, and untimely withdrawal of US aid funding caught us off guard, just as other provinces have indicated, and really caused significant disruption on ongoing HIV/AIDS, STI, and TB services within our province. And of note is that the initial communication about the funding cuts was directed only to the US aid-funded organizations, not to the Department of Health, which forced us to quickly pivot into action mode. Our immediate response involved conducting a situational analysis of the partners supporting the Department of Health in Mpumalanga and assessing the impact of their sudden withdrawal on service delivery. So we have a full report on that. But the entire province of Mpumalanga, encompassing all 3 districts, was supported by US aid funds. So this meant that the impact was widespread, touching every corner of the province. So critical health systems strengthening initiatives and the HES program were impacted. And we also saw the potential of compromised data quality and negative treatment outcomes if swift action was not taken. So we have 24 US aid funded organizations, including both prime recipients and sub-recipients who were directly impacted by the funding waiver. So if you look at the type of support they provide, we have paper US aid organizations, which were 12. They were supporting us in terms of TB, drug resistance, TB prevention, treatment, care and support, HIV care and treatment, including the DREAMS program, and key populations, also HTS at workplaces, focusing on vulnerable populations like MSM, BMMC, GPV prevention programs, as well as orphan and vulnerable children. So you see that really there's a challenge there. And we also have PEPFAR CDC organizations that were 3 that were responsible for key populations like the sex workers, people who inject drugs, and the LGBTQI groups. We have 9 PEPFAR community grantees also affected, and their programs focused on defaulted tracing, adherence support, psychosocial care, alongside home-based HIV services. In terms of our human resources and staffing challenges, we have lost a significant portion of workforce. This totals to about 398 staff members across various roles, including clinicians, that was about 100 of them, data capturers, around 177, and support staff. So if you break the totals down into the 3 districts, eThekwini lost about 188 staff members, Kgersibande 117, and Kangala around 93. If we look at resource implications with network availability, there are challenges there that we need to beef up around our external pickup points and vending machines. And, you know, in terms of data management, our partners, just for eThekwini alone, were contributing an estimated 130,000 Rand a month on data management, which is now a critical gap to address. And we know that the loss of these resources can directly affect patient retention, treatment outcomes, and the overall efficiency of health services in the province. So maybe also just to add that we do, however, have non-USAID funded organizations remaining, that is 30, and they also have various responsibilities around the HIV, AIDS, STI, and TB program. So I'll pause there, Chair, and hand over to you.
Thank you so much, Cheryl. I mean, it's just shocking numbers of staff it's basically shocking. Hassan, I don't know if you want to weigh in on my question about how this compares to the budget last year.
Yeah, I think these are two different processes. I think both are significant, and I think it wouldn't be fair. You know, that it's not an easy comparison, but I think just keeping in mind that this loss of funding with the USAID cuts affected mainly non-governmental organizations providing support. So those organizations were affected. And secondly, it's mainly the primary healthcare platform. So that's a significant difference. With the general austerity budget, you know, cuts, the process in this province was, as people were left the service, wherever they left, there had to be some form of motivation to replace. And then clinical staff were given priority over support staff. And, you know, only a certain number of posts were permitted to be appointed. And this is, again, across the platform. So hospitals, tertiary hospitals, district hospitals, and the primary healthcare platform were affected, although, you know, we tried our best to protect the primary healthcare platform, you know, from this process. But in the end, you know, as people motivated for posts, those posts, high priority posts, were filled, but the decision was then taken, you know, in last year, just to cut a number of posts, you know, from the platform, and it was really related to where people had left the service. And again, pushing the health system to look at redistribution, reorganizing, you know, transforming the health system. So austerity affected the health system directly in terms of loss of posts, whereas the USAID cuts affected mainly NGOs. So not that, you know, our staff directly, but impacting the service nevertheless. So both processes ultimately affected the services, but, you know, in different ways. Thanks.
Thanks so much, Hassan. So colleagues, I'd like to open it up to hear if there are any other voices that would like to enter the space, particularly other SALAD members from the Provincial Health Working Group, perhaps, or anybody else. I see there's lots of colleagues here that I know have been impacted. Anybody else like to say something? And we don't need numbers. We don't need the data. We'd be perhaps even more interested to hear a story about something that happened. Okay, if not, I'm gonna, oh, Gio, please go ahead.
Thanks, Susan. So I just want to point out that this happened to a far lesser extent about 8-9 years ago, when US aid was also had to change the stuff that they were funding in the Western Cape. And it was quite an acrimonious change at that time. And at that and because of that, we tried to limit our exposure to this organization. Having said that, they, to be very honest, they've really, as USAID officials, tried their best to mend the relationship over the last 8 years. And it was, we had reached a point where I think they were understanding our health system, and they were on the verge of actually strengthening our health system. So it's a massive disappointment that this happened at this time, and in the way that it happened. And the suddenness of this was extremely disruptive. In fact, is extremely disruptive. I think that's it, Susan. Thanks.
Thanks so much, Gio. Tony, I see your hand. Please go ahead.
Thanks. Afternoon, colleagues. So I just wanted to put this in here now because I think it's going to come up again, and that's not to lose sight of the broader picture. So we're talking about the USAID, the PEPFAR, whatever, but there's a much broader picture which is starting to bite us, and that is that the broad agenda of the Trump government is having far-reaching effects, and one of them is that it's making European governments increasingly nervous. They're withdrawing their funds from overseas aid, including research and a bunch of other stuff, and it's becoming increasingly difficult to get money from the British, the Swedish, the Germans, the Dutch, and a bunch of other people. So it's not just about USAID, PEPFAR, and the NHI. It's much bigger than that. Thanks, Sue.
I know, it's depressing. Beth,
Hi.
please go ahead.
Yes, thank you very much. Yeah, and thank you for this wonderful webinar. And one's heart sinks when you listen to all the stories of this massive shock to an already strained health system. And as Gio and Hassan has said, it's largely at the primary healthcare level, which is the area that we wish to strengthen. So the question I have is clearly to be able to respond in a coherent manner, and to make sure that your staff feel at least there's not control, but at least they can trust the system and there's hope. What strategies are being applied, and what processes are in place to make sure that staff feel at least connected and full of hope in this difficult time? Thank you.
Thanks, Beth. That's a very good question. I mean, I have some thoughts about what we're trying to do at TCT, but this is not about us. So I don't know if any of our speakers want to weigh in on that, or perhaps when I hand over to Reno, who's going to take over from me in a sec, that question can be brought into the discussion. And otherwise, Nokwazi, we saw your comment in the chat about just having to leave a district just like that. And I don't know if you would want to say that into the space, but it was a very moving comment.
Hi, yes, thank you for the opportunity. Yes, I was working for an NGO supporting the Nkangala district. And my worry, what I was thinking about in one of the days is our patients in the farm. We had patients there which were given TPT, others were given a TB treatment. Because our organization was an extension of the Department of Health, more especially to access those communities that do not have access to the health facilities. So there was no time to hand over, and I was thinking, what will happen to those patients? Is the department be able to follow up, since we know that they have a shortage of staff most of the time, will they be able to take over from what we're doing? That was just my concern as an individual. Yes, thank you so much.
Thank you so much for sharing that. So Reno, if that's okay, I'm handing over the baton to you, and you will also introduce Marlise when you get to it.
Thanks so much, Sue, and thanks to the panelists and also the comments and questions so far. Thanks, Sue. I just want to pick up on Beth's point and pose that question to the panel. It's an opportune question, and I mean the two questions I'd wish the panel to consider, because what I've heard so far in the room is the issue of pace and scale of disruption. If I could start with Cheryl and then Jabu and Hassan about how you are managing the immediate impacts in the province, and then also to consider, are there any positive outcomes of this move? Well, it's more disruptive move away from the US funding. And so, Cheryl, I wonder if we could start with you.
No, thank you very much. In Mpumalanga province, we have swiftly developed and implemented a comprehensive mitigation plan to manage the immediate impacts of the funding transitions and ensure continuity of critical services. Our approach basically centers around task shifting, skills transfer, and resource reallocation to maintain service delivery and minimize disruptions in patient care. So in terms of task shifting and reallocation, what we've done here is that we've looked at our ward-based outreach teams, and their key responsibility basically is, visiting households. So they will then assist us in terms of sensitizing our key population so that, they continue having access to our PHC facilities. Our community health workers, they will also assist and continue with patient education and also a monitoring to ensure that our communities have continued support and assist in terms of follow-up. So with our HTS counselors, our partners were assisting us with telephone tracing. So our HTS counselors will then assist in terms of follow-up or those patients that have missed opportunities. They will make sure they will assist us in terms of referring the clients to our facilities. Then with our professional nurses, they will continue with dispensing and to maintain continuity of treatment and prevent service delays. We had pharmacists that we lost from our partners. However, we have appointed pharmacists at our community health centers who will now roam and provide support to neighboring feeder PHCs, ensuring that medicine dispensing continues operating effectively. So in terms of data management and reporting, we are assigning our data capturers at all levels to ensure that essential reporting functions are maintained. And these data capturers will continue generating reports and ensure data integrity through regular verification and validation. So with our IT teams, they will then be providing support with a Cinch system, enabling the seamless data entry and integration. So with the M&E officers that we have, they will definitely have to step in to oversee the role of data management and reporting until new systems are fully operational. So we've also delegated our available data capturers for specific tasks to fill the gaps. And with our professional support and task shifting, our professional nurses have to continue with provider-initiated counseling and testing and ensure that testing remains available at all levels of care. So with our CHWs, we are looking at task shifting, where they will be capacitated to take over tasks that were traditionally done by other cadres of staff, such as linking patients to care and defaulter tracing. Health promoters will also be reallocated where necessary to strengthen outreach and education efforts. And then, of course, we will also be doing training and skills transfer, particularly to our clerks, so that they are trained in terms of data management. Our information officers at sub-district level will lead the training and mentoring and continuous support of what we call now data clerks. So yes, I think I'll conclude by saying that, you know, this mitigation plan has been developed at all levels within the districts. They've established task teams who will be assisting with overseeing that, you know, services are sustained in the midst of the crisis that we are facing. I'll pause there, Chair, and hand over to you.
Thanks so much. Cheryl, just a brief follow-up. I mean, clearly there's been a response that's been mounted and many things put on the table and executed. What would you see as potential positive outcomes or opportunities in this crisis, in moving away from the US funding? Maybe a few comments on that. Cheryl, I think you're still on mute.
I'm sorry about that. How we see it is that there'll be increased local ownership and autonomy. So we see that there will definitely be a reduced reliance on external donors, and that the Department of Health will have greater control over its own programs and priorities, allowing for greater alignment with provincial and national health policies. So I think as the province takes on more responsibility, there'll also be an opportunity for more tailored health interventions that are better suited to the local context. And the issue of sustainability, we can reduce dependency on external donors and create more sustainable and long-term solutions. It's also an opportunity for new partnerships. We are fortunate that we have the Global Fund and the 30 funded NGOs that are still supporting the department. So we also believe that we'll be moving away from we believe that moving away from external funding may encourage a greater emphasis on local capacity building with a focus on skills transfer and training of local staff. And this will help improve long-term health system sustainability and strengthen the human resource base. So yeah, it's also an opportunity for innovation, you know, encouraging innovation and, you know, I'll pause there, Chair. Thank you.
Thank you very much, Cheryl. I mean, it's always where you have this sudden impact that living with the sadness of the change, you also live with the opportunities that come from that, and there's stories on both sides of that. So thank you for that. If I could go to Jabu. Jabu, just a reminder of the questions about how you are managing the immediate impact in your province, and in particular, are there any possibilities of positive outcomes in this move away from US funding? Over to you, Jab.
Chair, let me start about the positive spin-off. I think Cheryl touched some of the positive spin-off, but because what we realize is that during this period, we saw that we are on our own, meaning that we can't completely rely from the external help. So we actually need to build system within the department. And the second opportunity that came here is that, you know, we are good in terms of verticalizing the programs. For an example, you had data capturer who's only dealing with DHIS. Then you had data capturers who were only doing the HIV, TB stat. So by pulling out, we're able to integrate those services. So it brought some integration in. And also, we also went back and looked at how do we go forward from here, because this is not going to, it's not like it's going to be, it's for a short period. It might go for a longer period. So we look at the HIV grant, and we look at also the district health services grant. And before, because it came at the right time when we were developing new grant for 2025, 2026. So we then went back and look at what are the gaps, which areas that have been hugely impacted by this move, and how do we make sure they are covered on the grant as we go forward. So that is what we have looked at. In terms of the firefighting that we were doing in relation to the pull-off, we have set up a firefighting teams that were able to identify areas with huge impact. We're clear that we can't solve all the problems. So we just need to tackle areas that have got huge impact. So we then, data management was one of the areas that had huge impact, because we also got support from partners. So we set up roving teams at the district level who will move facility by facility to try and catch up on all the data. And then the mobile services that we had, we made sure that they fill the gap of spaces, especially the home delivery of medication. So we integrated into the normal system of getting a mobile services, so that they can also deliver medication. And some of the patients, we had to tell them, sorry, you have to come back to the facility. Now we can't keep you where you were. So they came back and were able to actually continue with their meditation. So, and we during that time, we were almost on a daily basis. We're monitoring the services in the morning. We are also monitoring the services in the afternoon, so that we can deal with the issues that transpired during that day and make sure that everyone who was receiving care is not being compromised. So in a nutshell, those were the, or in terms of the because they also supported us with data for Wi-Fi and the others, so that we can run our systems. So there we approached the local business people, local people who are also offering services to us, to actually see whether they cannot support that part in the interim. Meanwhile, we're still seeing how do we then incorporate it to the health system now, going from 1st April onwards. So and then in terms of the technical expertise that we're benefiting from the NGO, that one we're still struggling with, but we have engaged the University of UKZN. Say now you need to come into this space so that you can support us going forward. Over.
Thanks, Jabu. Thank you. Lastly, I'll go over to Hassan. Hassan, I know that Geo watches over you, as you indicated.
Yes.
Yeah, if you could just speak to the immediate impacts and how you're managing that, and in particular the issue of reframing and positive outcomes for the funding moving away. Thanks.
Thanks. Yeah. No, it's interesting, being watched by the person who you are replacing, but I'm sure Gio will add his comments if I miss miss anything. So I mean, in the sort of immediate response was we, for example, for the pharmacies where we lost staff, we brought in agency staff, to help fill that gap. In terms of some of the staff that are funded by USAID, there's a small subset that are sort of embedded in the health system, and they're on what's called the G2G grant, and the province made a commitment to fulfill the contract requirement for those staff, which is for a year. So those were sort of two immediate steps that were made. And then in terms of what happened in the services, for example, the data capture load was then shifted to people to our existing internal data capturers who had to then, in the short term, take over those data capture functions. So those were sort of knee-jerk, quick responses that we engaged in. And then, what then sort of the next sort of level of discussion was sort of short-term interventions, and we have now looked at fast-tracking digitization of the health system, and as a way of improving efficiency. And then the second way was really a strong focus on what we call multi-month dispensing. So in parallel, there had already been a process to introduce 3-month multi-month dispensing. In other words, the patient gets a full 3 months of treatment. And then there was also the idea or approval for 6-month dispensing for appropriate patients. So again, this reduces the number of visits to healthcare services. And that's one way of then making the service a bit more efficient. And then using technologies like e-scripting and e-prescribing. We had already run a pilot on that, and it was really a question of expanding these kinds of mechanisms to make the service more efficient. And then there was we have a strategy called Make Every Contact Count. And part of that is to make counseling, for example, part of patient interaction. So we, of course, lost the number of counselors, but using this strategy, again, to fast track it or rapidly scale up so that the counseling services could be taken over or absorbed into consultation sessions, or that at least was the proposal. And there were the 2 clinics that were closed down, and again, the immediate response was to absorb them into the public sector. But it's not that straightforward. And I know that there are specialized services required for the trans community, and we don't have the capacity to absorb, the people who were currently or were being served by the NGO. So that remains a gap. And I think we mustn't be under any illusion that we have suddenly covered all the services that were lost. We haven't. We have not been able to. So, our services are disrupted. Data capture is disrupted. And we can already see, and again, from our discussion this morning, see losses or apparent losses in performance. And we have to look at the losses from 2 aspects. The one is not capturing data so that we don't see our performance, and the other is actual inability to track patients. So again, I think just important to emphasize that. So what does this mean in terms of opportunity? And again, just to channel Geo, he's always, as long as I've known him, within our district, warned about dependencies, raised questions about sustainability. He's, always made that an issue, and he's had frank conversations with the funders, with the NGOs about this issue. So fortunately, it's not a new conversation for us, and we, have always spoken or engaged with organizations about the sustainability plan. Of course, the quick disruption or the massive short-term disruption, none of us were prepared for. We thought we'd always have some time, but it's part of the organization's culture. So I think the big opportunity is digitization of services and making our services more efficient. HIV/AIDS and TB are our priorities. We shouldn't be outsourcing that to external donors. And too many countries around the world have done that. They've become completely dependent on donors. And it's our priority. We should own it. And again, it just reinforces the concept of taking greater ownership of the management of the TB and HIV program. Strengthening integration. But I think for me, there's another opportunity, and that is, it's again not about us. We don't exist in isolation. Working with partners is a good thing. But I think it's about who are your partners going to be? What are the principles? And I think there's a lot more discussion because there's a complete breakdown in trust, with this kind of funding cut. Would we ever want to have a funding relationship with the US government again? I think we would really hesitate and we'll be a lot more cautious. But who then should we be having relationships with? And in my view, we should be exploring South-to-South collaborations with other countries. They may not have money for us, but we can share ideas, innovations, and think about relationships and collaborations differently. And we've had engagements with, researchers in India. And again, they experience the same challenges, very similar issues, and they think in the same way. They understand our issues and we understand their issues. So I think what we should do is think about, what is the platform on which we build collaborations and help to strengthen our services. So, I'm on record of saying, BRICS is there as an opportunity. It's not to replace one dominant, force with another dominant force. I don't think that's what I'm arguing for. I'm arguing for principles of how we build relationships, and I think there's an opportunity for us to rethink who we partner with and think of partnering with like-minded organizations. Thanks.
Thanks, Hassan. And I just want to thank all three panelists, Cheryl, Jabu, Hassan, and Geo as well, because the chat is abuzz with comments. And so this is the time where I want to, and having heard the panelists, invite input from the audience. I just want to point to 4 speakers for the moment. And if I could get comments from Velile, then Jean-Marie and Beth, and then finally, Sue, you'd mentioned colleagues from Hero at UCT that may want to comment. But these have been really powerful inputs, and particularly the issue around how we reframe matters of partners and partnerships, funding, etc. So I wonder, Velile, if you wanted to start. You made quite a few comments in the chat and inviting others to do so as well. And then Jean-Marie after you. Thanks.
Thank you so much, Chair. I'm not sure if you can hear me.
Yes, clearly. Thank you.
I think you caught me off guard, but because I already put my comments in the chat. But I do think that this is a golden opportunity to really unlock partnerships that have been staring us in the face, but we got so used to getting it easy from all the partners that have been supporting us. But there's a lot of best practices that we can really draw from. And I know in KZN where I've worked very closely with Mndebele, Jabu. I was just making an example that we put together UKZN in collaboration with the provincial department, Jabu's office actually, where we were looking at, especially after COVID-19, we were looking at a lot of these conditions is around behavior. So how do we capacitate each and every healthcare worker as a behavioral change counselor, so that we are not only focused on very few people driving this mission, because the burden is quite huge, from prevention to really supporting chronic patients. And I know that that training was rolled out like virtually and is still available. And I think UKZN is, I think we also used it even during the MPOX response, because I think even National found it so useful. But there's such a lot of capacity we've been able to, and support that we've been able to draw from local tertiary institutions. So I was just reflecting on that one. Thank you so much, Chair.
Thank you, Velile. Could I just go to Jean-Marie? And I'm also going to ask if there are any NGOs in the room who have experience both in South Africa and outside who may wish to comment. If you just put up your hand or indicate. Jean-Marie, over to you.
Yeah, hi, thank you. So just for anyone who didn't read it, I had two questions, and they really aren't necessarily ones that I have answers to, but I thought there were a couple of comments that spoke to them. So the first one was just in response to Cheryl talking about, one of the strategies in responding to the cuts was around resource allocation. But the reality it really is that there's less resources than before. And so what needs to happen then, obviously, is a priority setting process, which is often done informally, particularly when there's a shortage of time. But I would be interested to know on what basis, if one thought it through, sort of on what basis different provinces are making that prioritization. Certainly what I heard from Western Cape was clearly a focus on primary healthcare, because that's where the resources have been lost, but also on I think it was vulnerable populations, people living at home, getting their meds, chronic care, and also digitization and the role of data, and trying to make sure that we don't lose data as a result. The second question I had was, given that there have been a number of comments about saying this is an opportunity to move away from disease silos, what responses are being implemented or tested and tried in different provinces that would specifically allow us to move away from that? And the one, again, that I heard coming out quite clearly was this issue of digitization, because it allows you to both address issues at the systems level, make sure you have the data to understand what's going on in the system, but also at a clinical level, because you've got patient level data that's being collected as well. So I'd be interested to hear in both of those cases whether others have other examples that are there. Thanks.
Thanks, Jean-Marie. I saw Paul's hand up, it went up and down. I wonder if I could just invite Paul to speak and then take further comments.
Yeah, hi. Paul Brunziza with City Health. So we in City of Cape Town. So Hassan and Gio, to a large extent, have voiced the kind of interventions we're doing, and we work very closely together on the innovations. I think system strengthening is one of the positives we've taken out of our engagement with the funded organizations, and I think we lack a bit of capacity in that, and we're trying to build it internally. But it must be stressed that at the end of the day, we started at a negative. There were resource reduction, budget cuts, and in my particular environment, all the way back to COVID days. So we are short-handed to start with, I must say. So our goal is to innovate and design ways around it. But the truth of the matter is that the primary healthcare platform is depleted. You could hear Hassan saying that in terms of pharmacies, they've had to look for agency pharmacies. So that's an agency budget. That's not a sustainable measure. We've done the same in the city. We've actually had to use an expanded public work program budget, which is now going to disappear, just to recruit clerks in the short run, just so that gives us an opportunity to fill the gap while training our existing clerks, reskilling them. And as we enhance our digital capabilities. But the truth of the matter is the Department of Health at the national level is going to have to stand back and take a good look at what the gap, that how many 400 or something million rands that was quoted up front has left us, and in terms of resources. We are going to fill gaps, but definitely the services are going to be impeded. There has to be a look at replacing a lot of the services, service providers we've lost internally. So thanks.
Thanks, Paul. Could I just check if there are any other members of NGOs who'd wish to comment and experience inside and outside of South Africa? Before I ask the UCT College just a few comments on modeling. And Beth, I've noticed you made a few comments. I wonder if you just want to highlight one or two in the context of this discussion. Sue, you mentioned the modeling, if I remember correctly. Who would be able to speak to that?
I wouldn't speak on behalf of my colleagues. Christina is in the room and just put a long comment there. I don't know if she wants to summarize that.
Yeah.
But I wouldn't want to summarize her work on her behalf.
Okay, I see there is a... Christina, if you want to make a summary comment, given what you've put in the chat, I'd appreciate that.
Yeah, so I mean, those are virtually the numbers. It's really hard to summarize it any further than what's there. But basically, we've worked probably since, well, the 24th of January with the National Department of Health to kind of summarize essentially both the budget needed to make up for the PEPFAR shortfalls, as well as the kind of the epidemiological impact of not, right? So, and that's of course also in order to have that, for them to be able to use that to make the case to Treasury. And it's not an economic case. So you know, some of us are going back 20 years when we kind of, you know, started talking about AIDS is your business and kind of talking to the private sector and workplace and all of that in order to make the case that we need to invest in an HIV response. We're also doing that. However, this is really just about averting deaths, destruction of livelihoods, and infections. So basically, in summary, so we have an optimistic scenario where we're just assuming that the 22% that of the expenditure in 2023, which is the last full data set that we have, if that 22% contribution that PEPFAR has been, you know, contributing to the South African HIV response, if that was not taken over by the South African government, and slightly differently between different program areas, then we'd have a certain impact. So that's our optimistic scenario. In the pessimistic, we assume that there are additional impacts on, so for example, PEPFAR funds 7% of testing. So in the optimistic, we just reduce testing coverage by those 7%. In the pessimistic scenario, we assume additional reductions. And I can't go into all the detail, but and I think those are kind of not too all extraneous kind of assumptions. We then assume that either this only happens over the next 4 years, and at the end of the current US administration, should there be another, you know, democratic election, this is all over. Another 3 years, we're full back to PEPFAR paying what they are paying for now. That's our recovery scenario. And the other one, basically, PEPFAR will never come back over the next 20 years, which is what we are modeling. So 4 scenarios. Basically, between those scenarios, we say we might be facing another, so basically infections going up by 150,000 to almost 300,000 just over the next 4 years, 2025 to 2028. Over 20 years, that would increase by between 300,000 and 500,000. If we basically recover and by 1 to 2 million over 20 years, if we never get PEPFAR back and the US and the South African government doesn't step in. In terms of AIDS-related deaths, we'd be seeing over the next 4 years between 56 and 64 or 65,000 additional deaths, and half of those are in children, and the average age of that is about 1.5 years, right? We know it will be babies dying. And again, that increases in the other scenarios. Costs will decrease, which is always a sad thing. If you take away services, the total cost will at first increase, but then from 29 onwards would increase over what we currently expect on a year-to-year basis. And so in order to make up for this, there were numbers bandied about earlier, and this is just at the national level. We're not even looking at 27 districts and how that is distributed. This is really just at the national average. We would be expecting between 11 and 24 billion rand that are necessitated over the next 4 years alone to avert this.
Thank you for that whirlwind. And people can read the rest in the chat. Appreciate the comment. Before I move off this, I just want to note the opportunities that have been in the chat around repositioning and reframing. The one has been commented by Hassan and others around South-South partnerships. And Beth has also put in the chat this opportunity that the Western Cape or other provinces may have around reframing and looking at the integration of health services from cities and provinces. I'll really just leave that in the chat, given that I would want to just move on to our next speaker. And I'm going to ask Marlise Richter to reflect on what's happening outside of the DHS. And Marlise, the question to you is, what are the other groups and activities across the health system managing, and how are they managing the impact and thinking about the future? Marlise is a researcher at the Ethics Lab at UCT and also at the African Center for Migration and Society at Wits University. Over to you, Marlise. Thank you.
Thank you very much. Can you hear me?
I can hear you clearly. Yeah.
Perfect. Thank you, because I have so many windows open, I wasn't sure. I want to just acknowledge the invitation to have me here this afternoon. I'm humbled by it, and I know that many people in this room are at the coalface of the funding cuts, and what I've heard this afternoon, yeah, I think is heartbreaking for all of us. My task this afternoon, and I'm going to keep it very short, is to reflect on some areas perhaps that's not been covered this far. And I just give a couple of some of the programs I've been involved in the funds. My background is health and human rights, and specifically population access to healthcare services. So you'll hear me emphasize the health of key populations a lot. And I was, where does an 800-pound gorilla sit? And that is anywhere it wants to. And for me, that was the image that's been sparked. Is it? Okay, super. The image of a very heavy, very powerful beast sitting where it wants to has often been what gets conjured for me when I hear about allies and friends in civil society and research institutions talk about what happens with the funding cuts. And I thought that that in thinking about this beast in the room, the metaphor is often mixed, because it's often associated also with the elephant in the room, that this was a good counterpoint perhaps for some of the very difficult issues that we are grappling with. And I would have argued before I heard speakers speaking today that perhaps one of the elephants in the room was the impact on key populations, which is in some forums not something that we hear often, is looking specifically at key populations. And then also an elephant that should be in the room, and it shouldn't be a secret elephant, is what the collective resistance efforts are underway. And I'm going to say one or two things about that. And it's mostly to direct people after this presentation if they want to follow up on some of those. This is a slide that talks a little bit, I think, what some of the points that Gesina's made around real-time timers that are showing us what the impact is on the ground all over the world in terms of how many deaths we can expect per hour if the funding cuts go ahead and are implemented at the scale that they have been suggested. Also, this timer makes, in some of the models of these two timers, at least that I know of, makes the assumption that even where there's been waivers specifically for PEPFAR funds, that those waivers can't be implemented because of the dismantling of USAID. And this is something that I think requires much more engagement and interrogation. This is one report that I just want to draw your attention to about key populations, and the research documented the increasingly hostile stance by the US towards key populations, and specifically in the efforts to cut down on diversity, equity, and inclusion programs, and that holds. And some of the early responses specifically to the PEPFAR cuts is how this has facilitated some of the discrimination, prejudice, and even hate crimes to manifest in some of the areas. We've seen some of this documented by the Treatment Action Campaign, some of the funding cuts, some of the rumors and concerns about what people are experiencing. And this article was a reflection by a treatment activist from the early 2000s and who expressed her fears about what is currently happening and being worried about the days of AIDS denialism and the work that had to be done there. My argument is not one that can be expressed in timers or in charts or Excel sheets. It's more of a qualitative analysis of what I've seen healthcare services are able to do for particularly marginalized and stigmatized populations. I worked in a clinic in inner city Johannesburg that was funded by US money, a second clinic in South Africa, and that was being rolled because of US money, and the immense benefits that are more difficult to quantify, especially with public health methodologies around the invisible glue that health services have. In this instance, sex workers, but this goes for people who use drugs, for the LGBTI community, and for others. And the clinic operating as a symbolic space, a safe space where sex workers can gather. They call it their own space. They can build cohesion for consciousness raising, politicization, and also the support that healthcare workers give in those spaces, and service providers becoming allies of sex workers and key populations. And this continued even though they were ideological constraints. Through the PEPFAR anti-prostitution pledge and the global gag rule, committed healthcare workers found creative ways working within those systems with continuing important services without falling foul of some of their contractual requirements. And with these funding cuts, these specialized services for key populations are falling away, and it's having a devastating impact on years' worth of relationship and trust building between healthcare workers and particularly marginalized groups, relationships that have been built with a lot of attention and care. I think something that was really hard for me and some of my friends and colleagues is how some health NGOs banned their staff from speaking to the media or on social media at the start of the PEPFAR cut specifically. People who are seen as allies and who would sometimes speak out for key populations were effectively muzzled. And I think that's created a bit more distrust. And then the reality that key populations can't just be absorbed into mainstream public health services. And most second elephant in the room is around this networks of hope and action that I think have been created historically during treatment action campaigns days, and that was generated or reinvigorated during COVID, and that I think has shown great solidarity by US, South African, continental activists coming together to try and buffer some of the worst excesses of the funding cuts. And here's some of the examples. This is a coalition of NGOs calling for an emergency plan. Francois Venter wrote very eloquently and ground up about what we need in this sensible emergency plan. And how there's an acknowledgement that we have to move away from donor-assisted programs, but that this current situation is requiring an emergency response, and we cannot move and have these very necessary structural shifts at the expense of the health of key populations. Then lastly, this was a really inspirational meeting that I was last week, convened by Zaki and other activists who's creating a coalition building around the funding cuts and what Trumpism means for health and equity. So that's definitely a space to be looking at, and these are some international sites where you can read about resistance. And just the bottom, the litigation tracker alone talks about 120 legal cases that's been filed in the US to create resistance. And then lastly, my appeal for working together and to push government specifically on implementing an emergency plan. I'm stopping it. No brain teasers.
Thank you, Marlise, for that input. Marlise, we have some time left. I'm going to just, do you have some advice for different institutions in the room, different organizations in the room about how to build stronger sort of South-South partnerships or partnerships between institutions, NGOs, etc., that you've picked up from what you've learned around this quick, rapid response in the coalitions that you've just mentioned? What lessons are there for academic institutions who are being impacted by the funding cuts, NGOs, for them to adopt a different coalition, for want of a better word? Interesting. I'd be interested in your comments on that.
Sorry, could you just repeat the question? There was
you've mentioned this whole realignment that you've spoken about, in terms of international coalitions, lessons from what you've seen for organizations in this room. NGOs are struggling, health services are struggling, and academic institutions are struggling. Any lessons for repositioning amongst these different groupings?
Yeah, I think that's a difficult question, and I think what I've seen in the chat box and some of the speakers here talking about new ways of thinking and how important it is to use the crisis in a way that looks at the longer term. I think that what I've seen, at least in some of the informal groupings and the activism there, has been the collaboration between different disciplines and different groupings, between NGOs, healthcare workers, community workers, lawyers, public health people, academics, and how it's almost seamless, at least in the virtual world of a WhatsApp group, of people working together and using strengths and filling gaps in terms of knowledge and perhaps ways of working. And I think that it's shown during COVID and before, during pushing for ARVs, how a crisis can bring sometimes unlikely allies together. And I think my appeal would be for people to work together in ways that might not present itself immediately, but to have multidisciplinary teams and different modalities work together. And I think that's part of our push for a national emergency plan, is for government to call many of these sectors together and to use the synergies there to come up with a robust forward-thinking plan.
Yeah. Thank you so much, Marlise. I have the inevitable task of trying to summarize this in a few minutes. We've got about 5 minutes to go. And so, first of all, I want to thank the panelists for their inputs and also then comments in the chat, which really has been stimulating. I suspect that we'd probably need to have another webinar on taking this forward. I'm sure this conversation has only started, so I just wanted to make a few observations given what I've heard and my own opinion. So I recognize that the pace and scale of this disruption has a human story to it, a personal story, and also a system story to it. Immediate job losses don't only have impacts on the person that has lost their job. We know in our South African situation, at least 3 other people and 4 to 6 person families are impacted. And we must not forget that is significant given the scale of the change. The second thing I want to acknowledge is that a range of stakeholders and a range of populations and vulnerable populations have been impacted from academic institutions, NGOs, vulnerable groups, etc. And thirdly, also recognizing that service delivery has been impacted in so many ways and described both in the chat and also by the panelists. I want to also acknowledge the opportunities that people have put on the table. I think some of these are probably longer standing ones, given that we expect more shocks worldwide. Tony's comment about, in a way, this is the beginning of a political and economic and world shift in power. It does behold us to take up the opportunity of us as groupings to find new partnerships, new ways of doing things, and really, in this room, adopting a values-based leadership approach and making sure that we, in a way, stand our ground in the interest of equity and justice. It means also that our governments need to own what is their responsibility as we co-work with our governments, and that we push for good governance, notwithstanding the crisis, or probably even better governance because of the crisis. That there will be and will continue to have health system changes, and that we, as part of that leadership group, and many people outside of this group in the room, need to be part of that change and chart the difficult territory and course that lies ahead. And there are 2 or 3 lessons that are global lessons that, if you are forewarned 5, 10, 15 years ago about owning your own process, owning your own country, and working together in a South-South partnership or other partnerships that are equitable partnerships, the level of dependency on others is reduced, and we are then able to chart our own course. I think, given that there have been shocks, and picking up from comments in the room, we have had short-term solutions to those shocks. What remains for us to champion and lead is how those are sustained, and I'm almost sure that those interventions will change over time. It would be quite fundamental to have a monitoring and evaluation framework to look at the impact of those interventions across a whole range of systems and services. I think with that, those last few comments, I take full responsibility for my words, and I thank everyone for putting their voices on the table in the chat and also from the panelists. And obviously these recordings will be available. So thank you very much for the participation. I also am required, I think, Sue, to announce that there will be future seminars planned for May and June. And may these webinars long continue with this level of engagement and debate. Sue, I'll hand back to you and for closure. Thank you very much, everyone. I thought it was a really good webinar with the inputs, the chat, and the panelists. Sue, back to you.
And thank you to you, Reno, for joining us to facilitate. I think that was a great webinar. Thank you to the speakers, and thank you very much to the team that does a huge amount of work in the background to put these webinars together. So thanks, colleagues, for coming, and we look forward to seeing you at the next one. And let's hope that we may all keep in touch and continue to build the connection and the solidarity going forward. So bye for now.
Ciao, everyone.
Bye, everyone.
Bye.
Thank you.
Bye, everyone.
Bye-bye. Keep well.